refreshed and ready for the last session. This session will be dealing with, after the tweets and the emails from Jill and Olivia, we'll be talking about palliative care and also children's services. Over to the...
Okay, this is the first one I've chosen off the scroll. It's worth, if you've got 5 minutes at the end, to have a read of some of these wonderful comments from you good people here. This People's Commission needs to be shown on national TV. We need a People's Commission for all the cuts that are taking place in our society. That's a good point too, sir. We need to show the world what is happening to our public sector. Well done, Lewisham, for leading the way.
Here's a tweet at Millwall FC. When you think you've seen it all, hashtag Lewisham people, just get better. Justice for Lewisham.
Sorry, this is going to sound like a big lit up session, but hey. Historic day, memorable day. This is a crucial part of campaigning to save our NHS, to save our hospital. Well done for getting all this startling and vital evidence out into the public arena.
Another one, thanks Toyin for sharing personal experience of maternity services and impact of losing them at Lewisham.
Okay, I'll be a bit naughty now and read a political one out, an obviously political one. Save Lewisham Hospital, rebuild the NHS, tax the rich and the banks to pay for it.
And finally, from Pete Sullivan, if Jeremy Hunt loses this fight, he should do the honourable thing and resign.
Anita Downs.
Good afternoon.
Hi.
Can you tell the Commission of Inquiry your name, please?
Yeah, my name's Anita Downs.
And your qualifications?
I work as I'm a registered nurse. I work as a palliative care clinical nurse specialist at Lewisham Hospital.
And can you tell the Commission of Inquiry why it is that you are giving evidence today to this Commission of Inquiry?
Okay. I suppose my role in Lewisham Hospital, I'm a community palliative care nurse specialist. That's sort of my side of the team. Part of my team also works with inpatients at Lewisham Hospital. I think that the TSA proposals are going to have a massively detrimental effect, both for patients as inpatients in the hospital and also in terms of how we link up services in the community. So that's what I want to get across.
Not to interrupt you, but I would like you to help the Commission with understanding what a palliative nurse is, to whom within the community you serve.
Okay. So palliative care is a term I have to explain quite frequently. So palliative care is about looking to focus really on patient comfort. So we're not looking at curative measures, we're looking at controlling symptoms like pain, nausea, breathlessness, but also looking at, particularly as in the community role, supporting people at home, to try and help plan for care at home to make sure that people's needs are met there. And a lot of the patients that I'm dealing with, well, the majority of the patients I'm dealing with are terminally ill patients.
Now, currently, the Lewisham Hospital has a team who deal with patients both within the hospital and in the community. Just explain how it works and the number of people that your team covers.
Okay. I don't have exact figures for our referral rates, but the ballpark figure that I've got from our consultant is that we see approximately, across the team, approximately 500 new patients each year, 300 of which are patients in the community. And As I said, our team's split into a hospital palliative care side and also the community palliative care. And we take referrals from GPs, from hospital doctors and other clinical nurse specialists. The patients that we see are all under Lewisham GPs. We don't cover it's a part of the borough, we don't cover the whole borough. And if a patient is named to us in the community and they're admitted to the hospital, then our hospital palliative care team then sees them while they're an inpatient. But separately to that, we also have hospital patients that are referred directly to our hospital team. Is that?
Yes, thank you. Now, sorry, it's a joined up service, isn't it? Integrated and joined up.
Yeah.
So the care that is given meets specifically the needs of the individuals that are using it. Is that right?
Yeah. So in the community, as I said, part of our role is to try and help facilitate to make sure that patients are receiving the care that they need, and we liaise very much with district nurses, with social services, with GPs, with a variety of different teams to make sure that patients are getting what they need in the community. I think there are some points that I was making about the fact that we're based in the borough of Lewisham and we're dealing with patients in the borough of Lewisham helps things to be joined up, because we've got a rapport with the GP practices that we cover, we meet them regularly. We're also familiar with the district nursing service in Lewisham, what it does and doesn't provide. And also we've got, especially now, we're having with neighbourhood teams, we're having more joined up working with the social services, particularly covering areas of Lewisham. So the fact it's all kind of in one area really helps join things up in the community. But the fact that our team bridges the community and the hospital mean that if people then come into hospital, we can foresee a lot of the problems that there might be on discharge and make sure that the appropriate services help the ward make sure there's appropriate services set up when that patient goes home. We can also, at the other end, try and help prevent unnecessary admissions to hospital by making sure that patients have got the care that they need so that they can stay at home for as long as that's suitable.
Okay, thank you very much for that. Is there a need for palliative care patients to access the accident and emergency department of Lewisham? Yeah,
so our patients, even patients that are known to us and who we've been supporting at home, they quite frequently do need to come to A&E. And a common reason for that is our patients are very ill. They have often got a number of comorbidities. Quite a lot of our patients have got cancer, which you can get lots of sort of acute complications as part of that, as that disease progresses. And some of those complications can be successfully treated by an admission to hospital. So in those instances, it's very medically appropriate for them to attend the A&E. Unfortunately, there's also instances where patients have to go to A&E because despite the best will in the world, things are not working out at home and they're not getting the support that they need at home. And for those patients, the hospital can be a safety net to make sure that they're kept safe.
So can we turn then to the Trust Special Administrator's proposals? What would that mean for your patients? What will it look like for them?
Okay. I think it will affect our patients on a number of different levels. For our patients who do need to go to A&E and have a hospital admission, it's very, very stressful for our patients to have to go into hospital because they're often very poorly, coming towards the end of life, and their families, of course, want to be with them as much as possible. The fact that they've got a hospital that can provide comprehensive care, which is very geographically close to them, is very important, and it reduces a lot of the stress that the families face in terms of from very simple things like making sure they've got the things they need in hospital to keep them comfortable, to being able to have the time to go and spend as much time as they can with their loved ones. That would be a lot more difficult and a lot more stressful if they have to go to Queen Elizabeth in Woolwich, partly because of the travel distance, but also I think because if the Lewisham A&E closes, that's an already very busy A&E, and they may have to wait for longer periods of time before getting settled and getting comfortable in hospital. and it's further then for relatives to have to travel to see them. But there's other issues.
Can I just may I ask you that? They may arise from this question. But the hospital team that currently exists, would that exist under the proposals of the TSA?
During the TSA consultation process, we've got 2 hospices that provide care. There's Greenwich and Bexley in Greenwich and Bexley, and St Christopher's provide some care as well. And there is actually proposals from those organisations for Greenwich and Bexley to take over the inpatient service and St Christopher's to take over the community service. I mean, I think on one level these are voluntary organisations who don't have full funding from the NHS, so I think there's an issue of funding there. So that's one issue. But in terms of the hospital, the proposals for the TSA would mean there'd be virtually no sort of medical admitting wards at all in Lewisham Hospital anymore. So we wouldn't really have a hospital team to do what they're doing now because the patients wouldn't be there to be seen.
If there is no hospital team, is that equally true that your team, the community part of the team, would go as well?
I think it wouldn't carry on as it is. We're quite a small team, as we are. We've got, administrative support. We have a consultant, we have a dietitian, we have a counsellor. We have all of these people supporting our team. If we didn't have a hospital team, there'd just be a few people working in the community, and I don't think it would be a viable team.
So what would that mean for the patient or the service users? What would that mean for them, those people whose lives are coming to an end? How will they be supported?
Yeah. I think as it stands, it's not clear who would be providing palliative care if the TSA's proposals go ahead. I think that's something that nobody, I don't think, in the Trust is quite clear about who would carry on doing that. But from a practical point of view, probably a lot of that service would be coming out of the QEH in Greenwich, and that would cause problems in terms of that then being in the borough of Greenwich as opposed to the borough of Lewisham. So if you have Lewisham patients in a Greenwich hospital, then you immediately have a whole different set of forms to fill out. People are not going to be as familiar with working with Lewisham social services, working with Lewisham GPs and Lewisham district nurses. And we face a bit of that problem sometimes because some of our patients live just over the border in Greenwich, and it creates real problems around who's funding what and are people being referred to the right place. So I think administratively that will increase the risk massively.
I'm very grateful to you. I don't have any further questions of you. Perhaps the panel does. Thank you.
You've heard his name, now you can hear his evidence. Professor Sir Bruce Keogh.
Thank you. Sir Bruce, just one question, in fact. Matthew Kershaw has accepted that his report had assumed that the children's unit at Lewisham would close alongside the current A&E department. What recommendations did you make in your review regarding this area of provision?
Well, full provision of paediatric services has been made in the plan, but is dependent upon clear definition and adoption of protocols of primary ambulance conveyance, an ambulatory paediatric urgent care service at Lewisham, and rapid transfer protocols for ill self-presenters. This must be considered a priority by the TSA for implementation.
Thank you.
I know this isn't scheduled, but now I've finished being other people. I do need to say as me that my daughter and my granddaughter might not be alive today if it hadn't been for the expertise of Lewisham Maternity Services.
Tony O'Sullivan.
Could you give your full name, please?
Tony O'Sullivan.
And what is your clinical job?
I'm a consultant community paediatrician, mainly working in the arena of childhood disability.
Yes, so could you explain about that? What does that involve? What does that entail?
We work in our community child development service based at Kaleidoscope, a children's centre up the road from here. For the last 3 years we've been united with the hospital, providing integrated care for children across the hospital and the community. Kaleidoscope offers a whole range of services for children with disability, including motor disability, cerebral palsy, autism, learning disability, sensory impairment, and also services for children who need safeguarding, children in the care system, placed for adoption, and we work with a range of therapists, nurses, and we also have co-located with social care, disability social work team, education, and the mental health service in what is actually unique in England.
And what is your other role?
That's my day job.
Yeah.
My other role is Director of Children's Services across the hospital and the community for the last 2.5 years.
So for the purposes of this People's Commission, what is your expertise?
My expertise comes from working in Lewisham for 20 years and having been part of building up the networks of care for children, often very vulnerable children, in a way that was actually in advance of government policy that was escalated after the Victoria Clambier death and the inquiry. But we'd already started building up networks across health agencies and across local authority agencies and indeed the voluntary sector to build that very necessary set of supportive environments for different groups of children, and doing that also with the hospital. We hear a lot about community-based care, which is a sort of kick in the face to hospitals, but Lewisham, to me, Lewisham Hospital is part of community-based care. It's certainly at the centre of our community, and as Anita has just said, it underpins safe community-based care.
I want to go back in time. What is your first experience of the NHS?
Well, that would be as a child. So my father worked in the NHS. He's Irish. Well, he was Irish. He's no longer with us. And he came to work in England before the war as a hospital doctor in training, sorry. And then he was in the war for 6 years, which he regarded as something that, although he's Irish, was a democratic issue against fascism. And then when he came out of the army, the NHS was fantastically formed, and he was a GP in Manchester for the rest of his professional career. And my first experiences that I vividly remember, he would be, as a GP in Manchester, he had a list of vulnerable patients, and just one example, he would give, we would have our Christmas dinner ready, and we would go out to one of the very elderly bedridden women in Gorton and give her the Christmas dinner before we started at home. And I thought that was pretty good. That was part of the NHS. It was one meal at least that was better than Meals on Wheels.
And what is your commitment to the NHS?
My commitment is total to it, because I think it's the most democratic achievement that we have in this country. It is the greatest contribution to health equality that we have, and although people talk about it as being free, it's not free. It's paid democratically out of taxation, and it's free at the point of need. So those who don't have money, either at the time or at all, get exactly the same care. And I think that's the right thing to do.
And Dr. O'Sullivan, why did you become a community paediatrician?
Well, I did thoroughly enjoy hospital training, newborn babies and general paediatrics, but I thought that the expertise that was generally centred around hospital in terms of specialisms, I don't mean GPs, that's a different specialty in its own right, but that expertise should be brought into the community. And so, along with others, where community paediatrics was a developing specialty, I thought we should be continuing to work with hospital, but build up a network of services that would actually facilitate children, for example, with disability, achieving in their homes, their nurseries, their schools, and bringing specialist therapy, specialist nursing skills, specialist paediatrician skills out into the community, and therefore working with GPs, with schools, and the hospital as well.
I want to ask you now about the TSA proposals. What are your main concerns about the proposals?
The main concern about services, as opposed to objections morally about what they've done, is that for 15 to 20 years we've been building up a set of networks in children's, and you've also already heard also in care of the elderly and mental health and all these other areas. And we've been doing it partly because we knew we should, and then later on because it's part of government policy. And then that is going to be destroyed because a major hospital is going to be taken out of the equation, and we will be relating one set of hospital in care service to a different set of social services, a different set of mental health services from 3 or 4 different boroughs, and it'll just return to the chaos that we had 20 years ago. So we'll be starting all over again. And the colleagues, if they are colleagues, that we talked to in the TSA process actually know they've done that.
So what does this mean for the children of Lewisham?
Well, it means that children in Lewisham and in Greenwich, I should say, are 2 of the most deprived boroughs in London, and they're in the top most deprived 8% of local authorities throughout England, so the top 8% out of 325 local authorities. And that's not a statistic alone, it's vulnerability. Lots of issues around it. One of the youngest populations, one of the most vulnerable populations, one of the highest populations of young children with sickle cell disease, for example. Lots and lots of risk factors that exist with deprivation are visited in Lewisham. Lewisham and Greenwich have the 2 highest numbers of very, very critically ill children that have to be retrieved from the hospital and taken to a paediatric intensive care unit in the whole of the southeast sector. So I'm starting from the fact that we have vulnerable, ill children in a deprived population. They're taking out the local hospital, they're reducing access to a deprived population with all the things we've heard, and it will lead to worse care. Absolutely lead to worse care.
So what provision has been made by the Secretary of State to deal with that and to plan for those children?
Well, he's not told the truth, but he's basically made a statement that the aftermath of his decision must be taken. What's the word? Somebody must have regard to it in the ensuing period, and that's not the way you plan for serious service planning changes. So he's given us a decision and sort of said, sort it out.
So there is no plan?
There is no plan. I mean, Sir Bruce Keogh has eloquently said that children's services that were well provided for by Matthew Kershaw, and they weren't provided for in any shape or form. There was no analysis of need, there was no description of current service, there was no proposals for this or that proposal, there was no risk assessment. You can't risk assess a proposal that you haven't made, and children were assumed as, the term I've used, as collateral damage of the major decision to close the hospital.
So what was the consultation about children and their needs?
I'm sorry, say that again?
Consultation. What was the consultation on the part of the Secretary of State in respect of children?
Including the TSA process?
Yes.
The consultation from Matthew Kershaw and the Trust Special Administration process was virtually zero. They set off last July with a structure of having forums for hospital-based care and community-based care. And I was unfortunate enough to go to 4 of these. And in the first one I went to, there was an analysis of the community's needs in terms of mortality, hospital attendance, numbers of procedures and so on. And there wasn't a single piece of data about children. So, and they'd been forgotten. So we raised this vigorously and said, I think you've forgotten 20% of the community.
Can I, sorry, if you could hold your thought, how many children are we talking about?
In Lewisham, there are 63,000 children under 19.
And Greenwich?
And across the 6 boroughs, over 300,000. In Greenwich, it's approximately the same, so about 120,000 for Lewisham and Greenwich.
So sorry, to go back to your, I hope you haven't lost your thread, in respect to those 300,000 children.
Sorry, I have lost my thread, I'm sorry.
And the consultation, what was said about those?
So, thank you, sorry. So, they huddled together and then they said that they would arrange a meeting. So they arranged a consultation meeting at the last minute, and it was maternity, which they also seem to have forgotten, was thrown together into one meeting, hastily convened along children as well. And as in the other meetings that you've heard about, we weren't discussing any details about actual children's needs. It was led by, you know, the consultants, McKinsey's, who got £5 million for it, and they were telling us to do blue sky thinking at a time when the storm clouds were gathering across South London. The only blue sky was McKinsey Consultancy's fees, I think. And so so we were unable to get into the actual detail, which is absolutely necessary. If you're talking about a wide range of diseases and conditions that children have, children are often regarded as a disease. You have diabetes work groups and oncology work groups, and then you have a children's work group as though they're a disease. But they're precious and they're complicated, and there was no planning at all done for it. And when that was raised with the TSA team, they were actually shamefaced about it.
So what was the data that was used?
Well, there isn't any data about children in the report. The only data is the births and the numbers of children that exist. And they had the birth rate wrong as well. I was at the same meeting with Jessica on maternity, and we challenged the birth figures they had because they were modelling it in such a way as to justify closing down Lewisham Maternity. And they were at least 2,000 or 3,000 births out for the sector because they were over 2 years behind in their data. And we said, your data's wrong. And they said, this isn't, you can't discuss the data, that's been agreed. This was a risk analysis work group. So I said, do you think it's a risk that the data's wrong? And they said, we're not discussing data. And then they finally agreed to put it down on the risk register that their data may be wrong. And they subsequently changed the data because they were wrong.
So to what extent has there been any professional analysis?
Of children's needs,
Yeah.
zero. I would absolutely say zero. And senior people in their process confessed to that.
That was my
private.
last question to you.
Okay.
Concerns your experience of those key players and what they've said to you.
Well, stop me if I'm going on too long, but the first episode was one of the public consultation meetings, and I raised the question of the health equality impact assessment not having been completed. And that's an essential requirement of major change, analysing proposals and risks. And Matthew Kershaw, at the end of that meeting, came up to me and said he apologised that the health equalities impact assessment hadn't been done, but that there was no time because of the timescale of the TSA process, which he suggested was being used in the first place last April. The second example was Matthew Kershaw. He's the TSA, I'm sorry, not to be personal. The TSA, the medical director of London NHS, and the medical director of the sector, the 6 boroughs, came to a meeting of consultants at Lewisham Hospital. And the medical director of NHS in London is actually a paediatrician. So the colleagues in the audience gave him quite a hard time. How could he forget children when he's a paediatrician? And at the end of the meeting, we had a conversation with a couple of those people present, and they actually said the TSA process should not have been used in the circumstances that they were facing. It was unjust for Lewisham. They recognised that networks would be shattered for children, but it was too late, and pardon the expression, they said, Lewisham Hospital has been shafted.
Thank you. I don't have any other questions for you, but there may be some from the panel.
Yes, could I've been going through this document all day, and I'm going to finish off with this same document. Tab 2, it is Bruce Keogh's provision of information to the Secretary of State, which led to the decision. This time we're dealing with your area. It comes right at the end of the letter. It was written this year, earlier. But since we're going to have to deal with what they're claiming, then I'm very interested. You've covered a lot of this ground. 30th of January. Anyway, this is the paragraph. The only other area of clinical risk I wish to highlight relates to paediatric care. Over the years, Lewisham has developed a respected high-quality paediatric service. Any alternative should be designed to be even better in terms of clinical outcomes and patient and parental experience. This is possible, but is dependent on very clear protocols for primary ambulance conveyance and ambulatory paediatric urgent care service at Lewisham, and rapid transfer protocols for any sick children who want to be better treated elsewhere. This will require careful pathway planning, particularly with the ambulatory paediatric service. This need is recognised in the proposals, but must be considered a priority by the TSA in the next stage of implementation. Then, I've read the rest of the letter in earlier stages. With these caveats, I would be content to assert there is a strong case that the recommendations are likely to lead to improved care. Now, I've read that all out because do we understand from what you're saying, in fact, that this is entirely speculative, what he's put here? There is absolutely no evidence base for any of the assertions.
Well, I would have to agree with you.
Oh, you don't have to, it's all right.
Well, I would have to agree with you from my professional experience and judgment and conscience that it's just disgraceful to say we've made a decision about children and the planning comes later.
Okay, thank you.
Just one moment. Joan Brown, here she comes.
Good afternoon. Hello. Can you inform the Commission of who you are and your connection to this inquiry?
My name is Joan Brown. I live and work in Lewisham. I have a child who has sickle cell disease, who is a 9-year-old.
Right. Can you please would you explain something about sickle cell disease?
Right. Sickle cell disease is a life-threatening disease. It is a disease that causes pain. When it is a blood disorder, that your child's blood, the cell is a sickle shape. So that sickle shape gets trapped in the vein and it causes pain. That pain can be anywhere in the body. And that pain can be extremely excruciating to the point where your child is screaming. And at that point, well, even prior to that, we have to take our child down to the hospital.
And how close does the hospital need to be to help your child, your daughter? How close?
Now, the hospital for us is a 5-minute drive. So my husband and I, if Drew is ever, my daughter's name is Drew, and I will use that name, her name, it is 5 minutes away, so we will rush her down in the car to A&E, where she will be basically seen immediately.
So she doesn't have to wait in the queue or anything like that?
No, she doesn't have to wait in the queue.
And where in the A&E does she go to? What
as soon as sometimes we because of the pain that they can visibly see the pain that she is in, we are immediately taken through and then everything is sorted out.
Is it the children's?
The children's, A&E? Yeah, the children's A&E. On a couple of occasions when my husband hasn't been at home and she's had a crisis, I've had to call an ambulance, and I've had to wait up to half an hour for an ambulance when my child, all I can do is cuddle her and console her. I can't take the pain away from her, waiting for that ambulance to come. If we had to go further away, then we would not be able to jump in the car and quickly get her to an A&E. We would have to wait for an ambulance because we couldn't really trust the traffic, and we wouldn't have that right of way to get her to hospital. When a child there is certain crises, like a chest crisis, that a child can have with sickle cell, which is very life-threatening because she can have a stroke, and the emergency for her to get to a hospital is really, really important.
How many times in the last year has your daughter been at the A&E?
Drew has been in A&E over 8 times.
And how many times did that result in an admission?
She's been admitted 3 times. Last night she was admitted to hospital, and I came out of hospital 12 o'clock today. She was at the point where at home we have a series of pain relief, and when the codeine is not able to stop that pain, we have to take her into hospital where she has to have morphine. First she will have oral morphine. If that's not enough, then we have to go with intravenous morphine.
How many times has your daughter had to have a blood transfusion?
Drew has had 4 blood transfusions in her life. She's had to have her spleen and her gallbladder out. When Drew's admitted to hospital, it could be for days, and it can also be for weeks. And when she was diagnosed with gallstones, she had to spend over 2 weeks in hospital, and eventually she had to have an operation.
If Lewisham closes, what will be the situation for your daughter and her care?
I intentionally got, because I'm a teacher, a job in this borough, so I could be near to the hospital and near to where Drew schools. If Lewisham Hospital was not as close to us as it is now, I'm not sure what can happen or what would happen to Drew if we had to wait for a long period of time to get her to hospital. Lewisham being right on our doorstep and Drew being treated right from 8 weeks there, we have got to know all the nurses. Drew knows the nurses there. Drew knows, the nurses know how to take care of Drew. When there have been situations where she's been so poorly that they cannot find a vein, and she's been injected 10 times, all right, the nurses know me and the nurses know Drew, and they can help support me to comfort her in order for that cannula or for her blood to be taken.
So if Lewisham closes?
If Lewisham closes,
no continuity of care?
There will be no continuity of care. Also, if I'm at home and I feel that there's a problem that I'm not quite sure of, I can email the consultant, but I also have the consultant's number that I can ring, and she will give me the right advice on what to do.
Thank you very much. I have no further questions, and thank you for sharing your story.
Thank you so much. On the timetable for the next witness, we should be hearing from Tina Sajanhar, who is the Children's A&E Consultant and the Deputy Director of Children's Services. But unfortunately, she is today on call and she is not able to be here. As I've said earlier, all of the witness statements are in the bundle, and so the panel will have those statements. So we shall go straight on to hear from Wendy Geraghty.
Could you give your name and your qualifications for the Commission, please?
I'm Dr. Wendy Geraghty. I'm a consultant clinical psychologist, and I'm the lead clinician for Lewisham CAMHS. I work for South London and Maudsley NHS Trust, and I'm responsible for the mental health services in Lewisham, and as such I'm also responsible for the services that liaise with Lewisham Hospital around emergency psychiatric presentations of children and young people.
Can you tell people what CAMHS stands for?
Yes, CAMHS stands for Children and Adolescent Mental Health Services.
Thank you. And how long have you been providing mental health services to children in Lewisham?
I've worked in the Borough of Lewisham since 1996. I became lead clinical psychologist in 2003 and lead overall clinician in 2012.
What kinds of vulnerabilities and needs do the children and young people in Lewisham have in respect of mental health services?
Well, there's a broad range of mental health needs. Only a small percentage of those are the urgent ones that they'd deal with at the hospital. But when children present in a psychiatric emergency, this is usually at a level that is serious. So it can be when they're feeling suicidal, it can be in relation to very serious self-harm. It can be the first onset of psychosis, which is incredibly frightening for the children themselves, the young people themselves and their families. Or it can be other very serious presentations of mental health problems that aren't dealt with on an outpatient basis.
What particular groups of children give cause for concern in Lewisham? I'm thinking particularly of looked after children and other children from at-risk groups. What's the profile?
Well, as has already been said, I mean, Lewisham is a young borough and a deprived borough. We have have specialist services for looked after children because there is a much higher incidence of mental health problems for that population. We have also specialist provision for that's co-located with the youth offending team because there's a lot of undetected mental health problems in that group, as well as learning difficulties. And there's a big incidence of mental health problems in learning disabled and autistic children. And all of those more complex presentations need considerable interagency working. And just commenting on Dr. Tony O'Sullivan, I've known him back to 1996 because of a joint interest in autism, and he's developed the autism services, for instance. So there's those kind of interagency links that are vital for these very, very, very vulnerable children.
So when you talk about interagency working, what range of agencies might be involved in providing the care pathways for children and young people with mental health problems?
It is very complicated, and it's really important that these are done right, because otherwise we end up by creating more work. So having said that, the agencies involved would be Children's Social Care, the Paediatric Service, obviously Child Mental Health Services, increasing numbers of voluntary agencies as well. And we're working very hard to create good pathways of care that will mean that there can be a step up in terms of need for children with mental health problems.
Now, you've given an indication of the kinds of disorders that might be affecting children and young people. What risks arise to them as a consequence of these disorders?
Well, the risks of those if you're thinking about the kind of critical situations that would take them to A&E, are quite high. I mean, for children who would have a psychiatric crisis that would mean that they might very significantly self-harm, they would cut. I know a young person who describes it A&E deep, which is that they definitely need medical attention. Swallowing batteries. So there are lots of ways of self-harming which are very serious to the health. Taking overdoses of pills in a way of coping with feelings or a demonstration of how bad they're feeling without necessarily thinking about the consequences. And this can be very serious, and there needs to be a very clear medical intervention at that point.
What about less acute risks?
The other risk is that they present, they develop a pattern of coping with emotions by self-harming or by presenting at an A&E. And unless they get the right psychological intervention, they can develop this as a way of coping with their feelings. And that can eventually lead to more and more presentations, maybe more expensive presentations of going into inpatient units where they learn more and more inappropriate ways of coping, and this can lead to in adulthood, then developing problems that would be seen as a personality disorder. So it can be expensive for our country.
I'm going to come on to the long-term implications shortly, because I know you've got a lot to say about that. But how key is early intervention in these cases?
I mean, I think it's key, obviously, for the children themselves, because if we can work with them and their families and their networks to find more appropriate ways of coping, of dealing with some of the real problems that can be around that their self-harm can be evidence of. I mentioned children's social care, and sometimes we pick up very serious safeguarding. Children have been sexually abused and therefore are self-harming. So it's important to have good networks of care around these children. We have good relations with Lewisham Children's Social Care, so we can very quickly do a team around a child and make sure that children's safety children are made safe early on.
So in this way, you're able to identify particular groups of children at risk of mental health problems?
Yes.
And intervene early?
And intervene with the other agencies. Most of the complex cases, you need to have interagency working.
What, in your view, would be the impact of the loss of the paediatric A&E facility? And I'd like you to start with the more immediate effects and then go into the longer term.
I mean, just to say, I mean, I don't know, I'm imagining a lot of people in the room have been to the paediatric A&E. It's a very impressive establishment run by very professional, dedicated staff. And we have done a lot of work with them to make sure there's good pathways of care for the children that we see.
Could I just ask, how long has it taken to build up these networks and pathways?
It's an ongoing process over years, it's important that the local A&E and the local child mental health services can work together and have relationships. And it's ongoing, and we would lose that if we didn't have the local A&E to relate to. It could be dispersed, is the term that's been used, amongst various other agencies. So I can't see that it would be possible to have that same relationship.
Now, some of the witnesses who've given evidence about the impact on adult services have talked about the loss of the ability to avoid admissions to hospital. Yes. Is that something that arises in...
Yes, I mean, that's a worry, is that an unintended consequence of this could be more expensive. We can't afford it at the moment. We can't afford to have less lean services. This would be a really expensive proposal the TSA had put forward as far as child mental health goes, because it will lead, I think, to more admissions and to children and young people developing ways of coping which is not helpful to their mental health in the long run, and will put more pressure on inpatient services, which would be obviously disastrous for those young people, but also disastrous for the public purse.
Yeah, so in a nutshell then, the appropriate way forward is to front load the cost of supporting children who may be vulnerable to mental health problems.
That, and also to have good, clear care pathways for these children. At the moment, we have we will offer someone from the local CAMS will go to A&E and assess and make a relationship with young people, and from that point of view, and then they'll link with CAMS and we'll be able to intervene. We won't be able to do that if they're sent to all sorts of other A&Es. There won't be that relationship. We won't pick them up at that point.
So there'll be a disruption to the services available to children.
Yeah. And I'm also worried that the children won't present, and so that'll either mean that there's an increase in terms of their physical health as well as their mental health not being dealt with. And if they do present, there won't be a continuity of service from whichever A&E they present at with our service. Now, so there won't be that.
Why won't the children present? Why won't the young people present?
The young people that we see are young people who are very deprived, who come from very difficult backgrounds, who aren't often who don't come from families. Often this is the case, it's a huge generalisation, but who wouldn't be able to get it together to go 2 buses or 2 buses and a train ride to Woolwich.
To where?
They'd probably more likely, as everyone said, go to King's. That would be very overcrowded. There isn't a specialist paediatric A&E there. They would be there in the adult A&E with all the problems that adult A&E has to cope with, including kind of, adult mental health and adult alcoholism and all the rest of it, which isn't a safe place for children. And they'll be waiting around. They wouldn't bother to wait around. A lot of our young people are very impulsive.
Do these general adult facilities have any specialist expertise in psychiatric services for children and young people?
The expertise comes from the local CAMS going out, and we work alongside, because for the older adolescents we do go into adult A&E to do exactly that, but they call on us and they call on our expertise, and sometimes we put nurses we will pay for nurses to go who specialise in young people if children have to be held in more adult facilities. but it's our services going out, and it's that relationship that will be destroyed.
And what about the long-term impact of failing to address and support children and young people with developing mental health problems?
Well, longer term, again, it doesn't make any financial sense as much as anything else, because they will develop chronic patterns of inappropriate ways of managing their emotions, and they are more likely to end up in the adult mental health service and in other institutions such as prison. And
so you're talking about an increase in juvenile crime which could have been avoided.
Yeah.
And how would you describe how far-sighted the proposals are?
I had problems in the documents that I've said. I haven't been part of the negotiations at all, but I've been reading the documents with interest. I haven't seen anything really that addresses child mental health in the thinking of the TSA. And there's been very little in terms of mental health generally, which is against the government's thinking in terms of the NHS mandate, which says that it has, these sort of plans should be holistic and should take account of mental health as well as physical health. And I haven't seen that in the thinking behind the TSA document.
Thank you very much. I don't have any further questions. The Commission may do.
Now our final witness, Louise Irvine.
Could you give your full name, please?
It's Louise Irvine.
And what is your role?
I'm a GP in Lewisham, in North Lewisham, and I've been a GP there since 1995. I'm also a Programme Director for GP Specialist Training in Lewisham, and I'm also Chair of the Save Lewisham Hospital campaign.
I want to ask you first about your practice. Where is your practice?
I practice in New Cross, Deptford, which is in the north of Lewisham, in a practice called the Amersham Vale practice.
And who are your patients?
We have about 7,500 patients, and there are people who live in the area in which I practice, which is in some of the most deprived wards in Lewisham, and Lewisham itself is one of the most deprived boroughs in England.
And how long have you worked as a GP in Lewisham?
As a GP, I've been a GP since 1988. I started working first in Lewisham in about 1990, and I've been a partner in my practice since 1995.
Why do you want to assist this inquiry?
As a GP, it matters to me the quality of care that my patients can access. Obviously, the parts that are within my control, which is within my practice, I try, along with my colleagues, to create as good a service as we possibly can for our patients. But we also depend on other services. We depend on services, the hospital services and community services. And therefore it matters to me because every single day I'm dealing with patients and I'm trying to help them help solve their problems. And some of those I can do within the context of our practice in primary care, but many times I need to link up with and use other services, refer patients into other services, etc. So the whole health economy has to work well for my patients to get a good service.
What are your main concerns about these proposals?
Many of the concerns have been expressed already. First of all, we have a very deprived population that actually have low income but also higher than average health needs. It's really important to them to access good care, and they do get good secondary care and community care from Lewisham NHS Trust. In terms of journey times, it's just outrageous to suggest that it's just as easy or almost as easy for patients to access care beyond Lewisham. Many of my patients will use public transport. They can get to Lewisham Hospital in about 15 minutes. We've tested as part of the campaign the journey times to Queen Elizabeth A&E, and on 2 different occasions it's taken nearly 2 hours for people to get there by public transport. So that's one thing. I think if patients are admitted to hospital, because of course if A&E closes, you're talking about closing the acute medical and surgical and children's wards, then sick patients will be admitted to hospitals further away. It will be very hard for patients from my area to travel, to visit their relatives. It will cost them a lot more. It will probably reduce the amount of visiting. And I think visiting is a really important thing for people to recover. We also have a very young population in my practice with a lot of women having babies. At the moment, they really value the maternity care they get at Lewisham. They do have choice. They can use the midwife-led unit, knowing it's co-located with an obstetric unit, or for the majority who are actually higher risk, they can go to a very good local obstetric unit. They won't have that care. They will have to go further away, Queen Elizabeth or King's or St Thomas's. And that will disrupt relationships that have been built up, care pathways, networks, and make it actually fragment the care that they get. And that leads on to the other thing about the whole, as GPs, we've been working in Lewisham, certainly formally for the last 8 years, as a sort of federation of GP practices. This predated clinical commissioning groups, and we've been working closely with Lewisham Hospital and with social and community care, and built up relationships, networks, and knowledge about how all these things can work together well for the benefit of patients. And that's something I'm really concerned about, that that's all going to be broken up if these proposals go through.
We've heard a lot about the process and the absence of process. What do you want to say about that?
About the consultation process? Yeah. First of all, the public consultation was only 30 days, which is really short. Most people found it really difficult to complete the consultation documents because they were very dense. They didn't explicitly say that they were proposing the closure of Lewisham Hospital A&E and acute services and Lewisham Hospital Maternity. They hid the map that showed that they were going to sell off 60% of Lewisham site was buried in the appendices, which most people in Lewisham didn't see. I went to one of the so-called consultation the kind of before the consultation process they had these sort of workshops with clinicians, and I went to the community care one because all of these all the TSA's proposals are based on this notion that 30% of the hospital services will be replaced by community-based care. When I went to that, it wasn't possible to really express any dissent. When one person asked the leader of the workshop what was the evidence that community-based care could reduce the need for hospital care, the person that was asked was Dr. Penny Dash, who was a senior McKinsey's executive and a senior member of the King's Fund, and Dr. Penny Dash's reply to that question was, there is no hard evidence. So they're basing a whole strategy on something where even McKinsey's, who are behind the whole consultation process, admits that there's no hard evidence. And whatever evidence there is, does not show that improved community-based care does reduce hospital admissions. Although it might be a good thing in its own right, but it doesn't necessarily reduce admissions, nor does it reduce costs. But in the workshop we went to, we weren't really allowed to talk about specifics. In fact, Lewisham Hospital wasn't even mentioned. We just were asked to indulge in blue sky thinking and aspirations and visions. That was all we could talk about, aspirations and visions.
I want to ask you now about the campaign. The Save Lewisham Hospital campaign. How has that developed?
That's been the most amazing experience. When we first heard that Lewisham was going to be included in the TSA proposals, which was sometime in September 2012, we, when I say we, I mean clinicians and patients and people who'd been, people from Lewisham Pensioners Forum, for example, we all discussed this and said, this sounds dreadful, we need to do something about it. And we had a meeting of just 12 people, and we said, well, we're going to have a public meeting to tell people what's happening, and while we're at it, we should have a march to protest. So we penciled in the dates, we organised the public meeting. We thought it would be great to have it in the hospital. The hospital very kindly let us have their auditorium. It soon became clear that the auditorium was going to be far too small for our public meeting. Not only did the hospital have to provide 2 overflow venues in the hospital for the meeting, but we had to organise at short notice an entire other venue at the Calabash Club, and even that people couldn't get into. So the public meeting had about probably at least 600 people turned up. And these were ordinary Lewisham people, people from across the borough, from all walks of life, and also Lewisham staff. And the feelings of anger, kind of disbelief, basically, and determination to fight it were huge. Then our demonstration, which we were liaising with the police, and originally it was thought there might be about 2,000 people, which we thought would be a good turnout. And we began to get the feeling from the street, because we were leafleting and having street stalls and talking to people, that a lot more people were going to come. So we said to the police, we think we better cater for 4,000. They said, no, don't worry, that's not going to happen. That doesn't happen in Lewisham. On the day, it was bucketing, windy, cold and bucketing day in November, and I thought, oh dear. Well, we had 15,000 people on that demonstration. And just talking about the demonstrations, that built up to Jeremy Hunt was going to announce his consultation, his decision at the end of January, and we organised a second demo in the snow, and it had 25,000 people on it. But as well as demonstrations, we had we had public meetings, we did a lot of petitioning, we helped people to take part in the consultation process, because as I said, it was quite a difficult document to understand, and we facilitated that. There were protests of mums and babies in buggies, mums and dads and babies in buggies in the snow, went to Department of Health to try to talk to Jeremy Hunt. He was in the building, he would not come down to talk to these 120 mothers and babies in the snow. He wouldn't come and talk to them. As well as that, we produced a very detailed critique of the proposals as well. We, as a campaign, did a detailed analysis, but we also were overwhelmed by the contributions from the Lewisham clinicians. So each department produced amazingly detailed, evidence-based critiques of the proposals, from emergency department to paediatrics to medicine to surgery to ENT to care of the elderly and so on. And they're all on our website. But we also had contributions from the churches, from the different dioceses. We had contributions from the Lewisham safeguarding team, from public health. So we had support from the council, and we had support from our local MPs, and we had support from across the borough, from every possible part of it. And that's why we had such a huge impact.
And just one final point on that, because I'm being reminded of our time. As chair of this campaign, what has this campaign shown you as to the people of Lewisham?
What has
it shown you? What does it reveal to you about the people of Lewisham? What it reveals
about the people of Lewisham is, A, they really value the NHS, and they're prepared to fight. They don't take things lying down. They are, I think they're prepared to show passion, but also intelligence. You know, the whole level of critique we've had today, and the evidence has been amazing. And I think people here are very determined. That's why, whatever happens, we're going to keep on fighting to defend our hospital.
Thank you very much. There's a question.
Sorry, could I just address one question to you more as chair than as a GP? Bruce Keogh in his letter says that the case for change is predominantly financial. He almost seems to admit that it's wholly financial, since no criticism of the standards of care and excellence at Lewisham Hospital is offered. So the financial motive. It's been commented on by a couple of people that Lewisham Hospital would be cheaper to close down than other hospitals lumbered with the PFI debt. But the other thing that hasn't really come up today, and perhaps you could help me with this, is, as I understand it, there's quite a lot of land that goes with Lewisham Hospital. Were it to shrink in size or to close altogether, there's a potential release and sale of that land. And I wondered whether you had any thoughts on whether that might be a motive behind some of the TSA thinking.
Yes. I think you're right to say that this is a financially motivated plan, and the role of PFI has been totally iniquitous in this, because the PFI has to be constantly fed, and you have to divert patients to the PFI hospitals to bring the money into the hospitals, and that means a viable, financially viable, good clinical hospitals like Lewisham are having to close to feed the beast of the PFI. And that also means, selling off land. If they sold off 60% of the site, that would go to developers to develop, I don't know how they would do it, but it certainly wouldn't be used for healthcare. And that money that's to be made from that is supposed to go to help pay the PFI debts of the neighbouring South London Healthcare Trust. I think that's, it's totally immoral to start with. It also doesn't make sense financially to close a financially viable hospital to help to sort out problems which were not caused by the hospital, and again, as Alison Pollock said, not even caused by the South London Trust, but caused by government policy. And it's, if you look at the sums, if you look at the costs of this whole reorganisation, it looks as if it's going to cost something like 196 million to do all the reorganisation and to rebuild some services in other hospitals. And that's only going to be save about £19 million a year. So it will take 10 years to pay off the costs of the money they're going to spend on this reorganisation of services across South East London. And we've even shown that those sums are wrong. It could take even longer than that. So it doesn't make sense financially. In fact, I don't know why they want to close the hospital. It just doesn't make sense.
And before I hand over to Michael Mansfield to sum up, I'd just like to say on behalf of the advocates that it's been an honour to be involved in this Commission of Inquiry, and we are thankful. We want to express our thanks to all the witnesses who've given such moving and powerful testimony today. Thank you very much.
I realise the time. I realise that you've been extremely patient. And may I say, I've been involved in many inquiries of different kinds. And this has been one of the most disciplined, most focused, and most efficient inquiries generated by public conscience, effectively. That's what a People's Tribunal is about. And you've demonstrated that time and again today through the quality of the witnesses, the quality of the evidence, as well as the organisation and obviously the advocates who sit to my left. And I want to thank the two judges who are sitting with me. We're going to retire, but in my case not actually, but retire to a room here to discuss various aspects of what we've heard, because we do want to issue a report reasonably quickly. There are various documents you've heard about that I've asked for today, and hopefully we'll get them in the near future. But we will have a sort of interim conclusions, because there's a judicial review next week, and there is a need to ensure that the public at large, well beyond the boundaries of Lewisham, recognise what is going on. It's going on in all the welfare services of course, but what is going on to their national health, and we don't want them suddenly to wake up, which they at the moment may do if they're not careful, to find that what they depended on since 1948 has disappeared. Now, I just want to say this about 1948. We will bear in mind what I've talked about, the United Nations Declaration of Human Rights and the right to health. But in 1948, a letter went through everybody's letterboxes. And the letter said this about the inauguration of the National Health Service: it will provide you all with medical, dental, and nursing care. Everyone, rich or poor, man, woman, or child, can use it, or any part of it. There are no charges, except for a few special items. There are no insurance qualifications. Not a charity, you're paying for it through tax. But it will relieve your money worries in times of illness. So, in a sense, that was the gold standard that was set in 1948 alongside the Declaration of Human Rights. None of this should be forgotten. And none of it should be forgotten in the context of what had happened in the Second World War. You were dealing with the ashes and embers of a nation that had been battered, a nation that had had its industry knocked out, but an industry that stood together, in one sense, in those ashes, and a phoenix was arising. So it shows what is possible, whatever the economic exigencies. And so we're very conscious of that background when we will come to consider everything that has happened today. I just want to light upon another resident that you all know about, that's in the news this week, Doreen Lawrence. And her example's the same as yours. It's Lewisham in a sense yet again. Because what she has demonstrated is the possibility of change. The possibility that she is not going to be told time and again by the authorities that it's all right, we're looking after your best interests, when actually behind her back, they're trying to undermine her, and that's only just come out this week. But she and Neville, who's not in the country anymore but was, fought very hard for the principle of public conscience being laid out and being effective. And in my view, she has led the way on that. And we today, you today, are giving us the opportunity to follow in those footsteps by what we want to look at here. And we're looking at the National Health Service with particular concerns. And I just want to highlight now, so if there are press here or if anybody else wants to know what our concerns are. We've had time to speak but briefly, so I say this is only preliminary. They're not conclusions yet, but they are concerns. The first concern is the absence of democracy. The democratic element, as you've heard today, was removed effectively, so the minister, now concerned, can just, as it were, slough it off and say, well, it's nothing to do with me, it's the market and all the rest of it. So you know that point. Second point, in relation to democracy, those that are still in Parliament, those who still, as it were, reserve the right to devolve responsibility, of course, those are decisions taken by, well, you've seen House of Lords and House of Commons. We'll get the figures for the House of Commons. I've been given one figure today. A very substantial proportion of those deciding this in our so-called democratic organs are part of the very vested interest that is going to profit from what is going on. So it's pretty clear that this is profit before people, no question. Yes, treachery even. And if there were a criminal offence that could be attached to that, I'd be in the forefront of trying to prosecute it. But however, and that just bringing it up to date with all the evidence you've heard today, another concern we're going to have is that when ultimately they decide that perhaps they ought to talk to you a bit, that they ought to consult. It's an insult and a travesty to call it a consultation, as far as I can see from the evidence. And our concern is that whenever a reasoned argument was put to the TSA on the various occasions, we had more than one witness saying effectively they were dismissed. No opposition was trucked. Now, what kind of democratic state is that, or would it be called oppressive state? We have an oppressive situation in which they're not effectively wanting to listen. So that whole element of democracy, I think, concerns all three of us, that is missing from this whole process. But then you have to ask a second question. The second question is, why is it happening? And of course, you have heard the answers today. In fact, they've provided the answer very clearly. And Blake just asked the question a moment ago, and I think I started the day with the same question, namely, it's not about Lewisham, in case you wondered, according to them. It's about two other hospitals in another area, and as being rightly pointed out, it's not the fault of those hospitals, it's the fault of a system that has produced, in a sense, set up to fail system, in which the private sector is once again going to profit. And the Pollock report, if I may call it that shortly, that's been leaked or released today and going to be published formally on Monday, makes it very clear that it is in fact a problem that has been created by successive governments. It's not just this one, but previous ones, going back to a Labour government with the private finance initiative, which means that hospitals, there are now 700 contracts, we learned today, are locked into an impossible situation in which they cannot possibly pay it off, unless, of course, this government were prepared to really go back to first principles, that this should be a properly publicly funded resource, and as the recommendation of that report is, that these private finance initiative has to be revoked. It has to be renegotiated. So our concern will be examining that process by which those contracts have come into place and have as essentially rebounded onto Lewisham. And it therefore isn't just about Lewisham, in fact, at all. It's about countrywide problems that are facing the NHS. They're not the fault of the staff, as far as we can see today, at all. The quality of care has not been questioned. It hasn't really been questioned in Lewisham at all. The recent report relating to obstetrics shows very clearly they're not only good, they're getting better all the time. So once again, it's a remarkable situation which we'll have to look at as to why on earth they should be looking at closing, or at least that was the original intention, downgrading. And we will look at the various aspects of the downgrade, whether it's the elderly, maternity, the travel prospects, the paediatric resources, and A&E, which, as the witness said today, what is it? Well, it certainly isn't A&E. Urgent care is actually not going to meet the needs of this community, which extends beyond Lewisham. And therefore, once you begin to look at all the component parts of what is failing here, which we will have to look at one by one, and there is the point about the land grab is of interest, because when you look at, there's a statement, the witness isn't here, I just mention her name so you can look it up. It's a quite remarkable piece of research by Cathy Ashley, who's a systems analyst and has worked as a district auditor. She went to one of the consultation meetings and found they weren't remotely interested in what she or anyone else had to say, and she was pretty horrified, as you may imagine, so we're back to that same point. But she took the trouble to get the draft report. She took the trouble to actually look through and look at the maps, which take a little bit of looking at. A lot of detail. I won't read out what detail she came up with. I'll just read you her conclusions. This is going to be another of our undoubted concerns. Look at the site, she says. The TSA wants to leave the buildings that are close to the river for hospital use, but to sell off all the land fronting Lewisham High Street. There is no means to get into this hospital. No cars, no ambulances, and no pedestrians. Well, that sounds interesting. I think that's the ideal hospital that the government want. Nobody in it. Nobody in it and no way of getting to it. And that's her conclusion. The fact that there is not even a means of getting into the site in this plan suggests that this is nothing more than a land grab to fund the failures of South London Healthcare Trust. And of course, as I've said, we're not blaming the trust, we're blaming the system. And that is going to be another further area of concern. Finally, the other area, I'm sorry, taking a little time so you know that we're examining this very, very closely. What is the basis? What is the evidence basis? And as a lawyer, I'm always concerned to see what the evidence, not the speculation, what the evidence is, if you're going to have far-reaching reconfiguration, which sometimes takes up to 10 years if you're going to do it properly, which means not only consultation, but you actually have to know what the impact is going to be. And you don't know the impact until you've discovered what it is that you're serving. What is the community? What are their needs? Well, it's perfectly clear from today, and also from the written material that we have, this is an area we'll examine very closely because it so far appears there was absolutely no evidential base, and the basis that they did come up with, the 100 figure, of 100 saved lives, nobody knows where they got it from. They haven't been able to reply in any of the letters that we've so far got from the TSA or anyone else is the evidential basis, no research. And perhaps the height of that was the paragraph I put to Tony O'Sullivan, namely in the paediatric sector. It is a complete misrepresentation, it is complete speculation, and they take decisions on the back of it. Well, we want to demonstrate through this report that the public are no longer going to put up with being misled, with false information. The public are no longer going to put up with oppressive dictatorial diktats, essentially, from a government not interested. They always say lawyers take 4 minutes to cough, never mind speak. So I haven't got one. It's all right, doctors, don't rush. I just want to say thank you very much for your patience, and thanks to everybody, including the mayor, for allowing us to use this theatre today, because it's been a wonderful experience, one in which I think very few of us will ever forget. Thank you.